Welcome you all in Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, I'm teacher by passion and pediatrician by profession. So, we are continuing this amazing series of fast track revision pediatric series for NEET SS pediatric exam. So, this is second part. We are covering neurology in this part, pediatric neurology. As we all know, neurology is a very vast subject. Even in pediatrics, it is having neurological disorders, neuromuscular disorders, genetic disorders. So, covering neurology in a short span of time in just 30-40 minutes video, it is impossible. Okay, so what I'm trying to do here, I'm covering the most important topics and previously asked topics in that neurology part. So it will cover approximately 60 to 70% of your questions. So these actually you can't miss because this is very much important. And be with me. What I need is full attention from your side. You can revisit, rewind any part if you want to see again. And this is basic CNS revision. Hope your CNS part will be better by seeing this video. Okay, so we are continuing this series. This is second lecture, and keep watching the playlist of this series. This will be very beneficial for you. So without further delay, let's start our discussion of the star topic today is that is central nervous system neurological disorders in children. So this topic, all we know, is very important. Okay, so first we'll start uh, the screening scheme or developmental delay. So what is the upper range of the milestones? Okay, very important to remember. First thing, at 3 months of age, what is the upper limit? We'll divide them in gross motor, fine motor, social skill, language. Just go through important points. Support weight, open hands spontaneously, smiles appropriately, and coos and laugh. These should be covered in 3 months. This is upper range. Next milestones is asked is at 9 month of age. Sorry, generally asked: pull to stand, pincer grasp, play pat a cake, peek-a-boo, and imitate sounds. Next is asked at 1 year of age, walks with one hand held, releases an object on command, comes when called, 1 to 2 meaningful words. Next is 2 years, runs, build a tower of 6 blocks, play with others, 2 to 3 word sentences. It might look exhausting and threatening to remember this, but just trust me, 2 or 3 questions has been asked multiple times from this table only. So just go through once and you will be good to go. Okay, so this is PYQ, papilloedema image has been asked in exam directly from Nelson. So this is papilloedema showing severity from mild, moderate to severe. Okay, timing of selected primitive reflex. This question is all-time favorite to MBBS, to PG examiners, to super specialty examiners. So we'll dissect it. Palmar grasp. They'll ask in NEET SS, they'll ask onset, fully developed and duration. All three things will be asked. 28 week of gestation it starts, fully developed at 32 week of gestation, and duration is 2 to 3 month postnatal. Routing approximately similarly, just ahead of Palmer grasp, 32 week of gestation at onset, fully developed at 36 week of gestation, and 4 to 6 month postnatal it is duration of this reflex. Morose, the star topic, it onset is 28 to 30 week gestation, 32 week gestation, remember this. Fully developed at 37 week of gestation, duration is 5 to 6 month postnatal. Tonic neck posturing is 35-week gestation, fully developed at 1 month postnatal, duration 6 to 7 month postnatal after this rolling started. Okay, then parachute reflex, it starts at 6, 7 to 8 months postnatal and fully developed at 10 to 11 month postnatal, and it remains throughout the life. So this is important consideration of all the primitive reflexes, you have to remember all. Okay, Next, again, a very important table. Okay, look, what I'm discussing is ultra high yield. You can't skip any topic which I'm discussing. Obviously, you can go through other topics which is not covered in this series or video, but those I'm discussing are very important. Important, you can't skip them. Okay, you saw a child with occult spinal dysraphism. Anything from a spinal cord is abnormal. So, will you go for MRI, CT, or any other investigation? Yes. In which cases? Very important. Imaging indicated in subcutaneous mass or lymphoma. Lipoma. You found a subcutaneous mass or lipoma, go for MRI. Hairy patch, go for MRI. Okay. Dermal sinus or cyst, go for MRI. Atypical dimples, if it is dimple is deep, this question is PYQ repeatedly asked. If dimple is more than 5 millimeter and more than 25 millimeter from anal verge, go for MRI. Vascular lesions like hemangioma, telangiectasia, go for MRI. Skin appendages or polypoid lesions like skin tag, tail-like appendages, obviously you go for MRI. Scar-like lesion, aplasia cutis, you have to go to MRI. Just see, imaging not required. In which condition imaging not required? Simple dimples less than 5 millimeter or less than 25 millimeter from anal verge and coccygeal pits. So this was PYQ. In coccygeal pit, MRI is not required. Uncertainty is there in hyperpigmented patches and deviation from of gluteal fold. You might do or might not do. So coccygeal pit, atypical dimple, and aplasia cutis was previously asked these three questions. So this table is very much important. Just pause this video and revise these indication or not indication once again. Okay, so preferred imaging procedure in neurological disease. This is exhaustive looking table. We will not go in this table as a whole, but we will see in ischemic infarction or transient ischemic attack, what will be your first investigation? CT head and neck, because you don't know what is the pathology, it might be hemorrhage. So this question is again PYQ. And if next step is MRI or MRA. Okay. Intraparenchymal hemorrhage, very important, previously asked question. If timing is less than 24 hours, go for CT scan. If more than 24 hours, go for MRI. Cerebral aneurysm, CT without contrast for acute subarachnoid hemorrhage, and MRA or CT to identify the aneurysm. This is very important. Hypoxic ischemic brain injury, will you directly go for MRI? No. USG in infants, in older children, CT if unstable, otherwise MRI. Metabolic disorders, obviously you will go for MRI. Head trauma, the first choice is CT scan without contrast. Okay. Movement disorders, obviously we will go for MRI. There are other disorders also, but I have highlighted the important one. You have to go through these all. Okay. So this is amazing. Image based questions has been asked multiple times in different exam. So just see, the first image is showing midline sacral hemangioma. So this question has been asked as such in exam, midline sacral hemangioma. This patient of occult lipomyelomyelocele. This is, are you able to see the subtle patches hyper trichosis with a dermal sinus? So this is hypertrichosis with dermal sinus because this is a capillary malformation. Are you able to see human tail? We just discussed in human tail, we have to go for MRI. So this is human tail with underlying lipoma. So this is a case of lipomyelomeningocele. Okay, last, this image midline area of hypertrichosis overlying a patch of hyperpigmentation. So these congenital median lumbosacral cutaneous lesions are very important for exam as well as clinical practice point of view. This image is showing occipital encephalocele. Okay, very important. And anencephaly. Okay, this is Oski spotter also, and example spotter also. Image of anencephaly. Okay, next, what are the causes of microcephaly? So, just remember, isolated microcephaly can be there. What we are concerned about, syndromic microcephaly. What are the syndromes? Trisomy 13, 18 and 21 can cause microcephaly. But just remember, chromosomal deletion disorders like Wolff-Hirschhorn disease, 4p deletion, very important. Cry-do-chat syndrome, 5p deletion, and 7q11 deletion Williamson syndrome, and 17p deletion Miller-Dieker syndrome. So Wolff-Hirschhorn syndrome, Cry-do-chat syndrome, Williamson syndrome, and Miller-Dieker syndrome are the common cause of microcephaly, syndromic microcephaly, very much important. Fanny-Gold syndrome has been asked in exam. It is one of the cause. Don't try to remember the gene, but Fanny-Gold syndrome, yes. Cornelia de Lange syndrome, Smith-Lemmy Optis syndrome, and Robinson-Tybee syndrome. Just remember name of these syndrome. It is sufficient. Rett syndrome, Angelman syndrome are also important. Intrauterine infections can cause teratogens like alcohol, hydantoin, radiation can cause, and the important consideration maternal hyperphenylalaninemia. If phenylalanine is high in maternal condition, it can cause microcephaly in infant. Maternal diabetes mellitus and obviously hypoxic ischemic injury. So just remember this table is very important causes of microcephaly. Next, disorders associated with agenesis of corpus callosum. Somehow this topic is favorite for examiners. Just remember the syndromes: the Barrow syndrome, Mowat-Wilson syndrome, pyridoxine-dependent epilepsy. This gene has been asked multiple times. ALDH7A1 gene. So this gene is important. And again, Aicardi syndrome. This is ACC with chorioretinal lacunas, infantile spasm, and MR. Okay. The next is Meckel-Gubler syndrome, encephalocele, polydactyly, and polycystic kidney disease. Okay, so these are very important because one might be thinking of how these syndromes are important because they are associated with agenesis of corpus callosum. Next, non-ketotic hyperglycemia. This is important. Okay, ACC with cerebral atrophy, myoclonus, and progressive encephalopathies associated with this. Robinson-Tybee syndrome, septo-optic dysplasia, also called as de Morager syndrome. So, de Morager syndrome, another name is septo-optic dysplasia. Soto syndrome is also important. Okay. Next, so again I'm highlighting this. This is very high yield, ultra high yield topics from CNS. So just pay attention. I'm going very fast because otherwise this topic will not be completed. So, risk factor of recurrence of febrile seizures. A patient came to you and her or his parents are asking for recurrence. So, what are the major factors and minor factors? Just see major factors: age less than 1 year is major factor, duration of fever less than 24 hours, and fever 100.4 to 102.2 Fahrenheit. These are three factors are major. What are the minor factors? Family history of febrile seizures, family history of epilepsy, complex febrile seizures, daycare, male gender. Just remember it is not female, male gender, and lower serum sodium concentration at the time of presentation. Okay, you categorize the patient into these major minor risk factors. If there is no risk factor, approximately 12% risk of recurrence. If one risk factor, 25 to 50%, two risk factor, 50 to 60%, and three or more risk factor, approximately 73 to 100% risk factors. So you can tell parents the recurrence of next febrile seizures will be like that in these risk factor categories. Okay. If a patient attendant asks or parent asks you, what is the risk of subsequent epilepsy after febrile seizure? In first table, they are asking risk of recurrence of febrile seizure. But in second thing, what's the recurrence of epilepsy after febrile seizure? You can tell them if simple febrile seizure is there, 1%, recurrent febrile seizure, 4%. If it is complex febrile seizure, 6%, fever less than 1 hour before febrile seizure, 11%. Family history, 18. Very important. Repeatedly asked question. Complex febrile seizure, focal variety, 29%. If focal complex febrile seizures are there, chances of epilepsy are 29%. Any neurodevelopment abnormalities having chance of 33% of febrile seizures. Very important. Okay, so just go through these table once. These are very important. Just pause and rewind this video. Okay, metabolic disorders associated with epilepsy syndrome. We are very well versed with pyridoxine. So the gene is very important. ALDH7A gene and PNPO gene. Just remember gene. Biotin can cause seizures. BTD gene, obviously. Folic acid can cause FOLR1. Myoclonic aesthetic and myoclonic GTC. Very important. Glycine, it is glycine. Non-ketotic hyperglycinemia, not hyperglycemia, it is glycine, very important. Glutamate and uridine can also cause. From this table, just remember this glycine, folic acid and pyridoxine gene, which are very much important, and 18%, 29%, 33% are important. Obviously simple febrile seizures, 1% is important. Okay, next we'll go some EEG pattern given in book, Nelson textbook of pediatric. So the first EEG showing spikes. You're able to see these spikes. These are in left temporal lobe. So if left temporal lobe involved focal spike, this is mesial temporal sclerosis. If these spikes are left central parietal, okay, so this may be Rolandic epilepsy. These may be centroparietal spikes, as name suggests, Rolandic epilepsy. In next, you're able to see 3 hertz of frequency. So this is absence seizures. If 1 to 2 second frequency is there, slow spikes are there, LGS will be the answer. Are you able to see chaotic background? This is hips arrhythmia. 4 to 6 hertz spike after photic stimulation. Classical history will be there. This is JME, juvenile myoclonic epilepsy. Okay, so a recommendation of treatment of pediatric epilepsy, we just go through fast. Focal onset, all we know, carbamazepine and oxcarbazepine, just go highlighted. And Rolandic epilepsy, also called as BCT epilepsy, carbamazepine valproic acid. Childhood absence epilepsy, all we know, ethosuximide and valproate. Juvenile myoclonic epilepsy, levetiracetam, lamotrigine, topiramate. Lennox-Gastaut syndrome, multiple drugs including rufinamide, lamotrigine, clobamate, clobazam also. Infantile spasm, ACTH and vigabatrin, and primary generalized tonic-clonic seizures is levetiracetam, topiramate and other drugs. So just remember highlighted one. These drugs can be asked what is the drug of choice. Okay, very important favorite topic of examiners. What are the side effects of anti-epileptic drug? There are many side effects. Just remember highlighted one. These are previously asked questions. Every highlighted topic side effect is previously asked. Just be with me. You will remember this. Acetogenamide causes renal calculi. Don't remember polyuria, electrolyte disturbances, Stevens-Johnson syndrome. These are there, but the important and differentiating side effect we have to remember. For benzodiazepam, dose-related neurotoxicity, drooling. Brivacitram, depressed mood. Bromide, spurious hyperchloremia. Once question was asked, spurious hyperchloremia was caused by bromide. Carbamazepine, as we know, transient leukopenia, hyponatremia, weight gain, agranulocytosis, aplastic anemia. Very important. Cenobamate dress syndrome with short QT interval issues. Clobazam drooling, very important, and practical drug also in clobazam drooling is a problem. Phlebamate, hyperactivity, dizziness and hematological toxicity. Gabapentin, acute onset of aggression, weight gain. Leukosamide, cardiac arrhythmias can be predisposed. Lamotrigine, headache, ataxia, dizziness. Levetiracetam, asthenia, dizziness can be there. Oxcarbazepine, hypertrichosis, gingival hypertrophy, and hyponatremia. Next, the previously asked question, suicidal thoughts and behavior from which drug? It is perampanel. This drug has been asked twice. Okay, aptoin and hydantoin, all we know. This drug can cause gingival hyperplasia, causing of facies, hirsutism, cerebrovascular symptoms. Pregabalin, this drug can cause weight gain, thrombocytopenia. Primidone, CNS toxicity. Succinamide, hiccups. Rufinamide, it is contraindicated in familial short QT syndromes. Then tigabine, headache, tremors, precipitation non-convergent status epilepticus. Well, topiramate, renal calculi, again previously asked question, hypohidrosis, fever and glaucoma also. Valproic acid, all we know, weight gain, hyperammonemia, tremors, alopecia, menstrual irregularity. Vigabatrin, V for visual side effect. Zonisamide, ataxia, hyperhidrosis, renal calculi. So these were important side effects of important anti-epileptic drug. Just pause this video and revise them once again. Only highlighted portion, you will be good to go. Okay. So, and precision therapy means any gene mutation and epileptic disorders. These genes are favorite for examiners because now a time is coming of genetic things. Genetics rise. So, ALDH7A gene we have discussed earlier also. This is pyridoxine dependent epilepsy. FOLR1, this is cerebral folate deficiency we discussed. KCNQ2, this is important and previously asked also. This is benign familial neonatal or infantile seizures. PNPO, pyridoxine 5-phosphate dependent epilepsy. SCN1A, very important gene, favorite of examiners. Dravet syndrome, GFS1, other disorders. SCN2A, brother of this. This is benign neonatal infantile seizures, Dravet syndrome. Just remember one more, SLC19A3, biotin thiamine responsive basal ganglia disease, and TSC1, TSC2, all we know, tuberous sclerosis complex. So these are bare minimum genes in consideration of epilepsy you have to remember. These are frequently tested, and if you remember them, this is upper age definitely. Okay. Next, pyridoxine dependent seizures. If you go further, if you want to, this is optional. If you want to just go ahead, just see this table. Pyridoxine dependent seizures, what will pipecolic acid in CSF will be increased. Again, INICET repeat question. And what you will do, urinary and serum AASA level. So this is important. Okay. Pyridoxine phosphate deficiency, obviously pyridoxine 5-phosphate oxidate gene testing will do. GLUT1 deficiency, again important question, CSF glucose will be less than 40 mg per deciliter or less than half of serum glucose. Investigation of choice, PET, FDG, PET, very important. Non-ketotic hyperglycemia, increased level of glycine in CSF or plasma, it will be there, and creatinine deficiency syndrome will be seen by MRI suggesting of demyelination. MRS reveals absent creatine peak. So just remember, this is just extra edge. Okay, Status epilepticus treatment. I hope all be well versed with this treatment, but just see the 0 to 5 minute phase. We have to see glucose. We have to give in adults 100 milligram thiamine is also given along with 50 ml of D5, D50. In children less more than 2 years, 2 ml per kg of D25, and children less than 2, 4 ml per kg of D12.5. This is very important. Hypoglycemia management in status epilepticus has been asked. The drugs initially you have to give midazolam, lorazepam, diazepam. Next, phenobarbital, rectal diazepam, intravenous, intranasal midazolam. Next, phosphenotoin, valproate, levetiracetam, and next coma stage. So just remember, I'm not repeating the doses. Just pause this video and just try to memorize the doses which are important. Okay, so this is work for you. Next, very important, a patient journal routine OPD issue. A child came in your OPD with headache. Will you go for directly for MRI or CT, or you will prescribe some NSAIDs? So in which cases you have to go for imaging? If you did neurological examination, it is abnormal, go for MRI. You found any focal neurological signs, okay, go for MRI. Seizures with headache or very brief aura less than 5 minutes, obviously go for MRI. Unusual headache like atypical aura, basilar type, hemiplegic, trigeminal autonomic cephalgia, and secondary headache. Headache in children less than 6 year old because he can't describe, go for MRI. Brief cough headache in child or adolescent, just go for it. Headache worse on first awakening, and migrainous headache in child with no family history. Again, I'm highlighting the important things: abnormal neurological examination, abnormal focal neurological signs, seizure or very brief aura, unusual headache like basilar, hemiplegic, trigeminal autonomic cephalgia, headache in children less than 6 year old, brief cough headache in child or adolescents, headache worse on first awakening, migrainous headache in child with no family history. Just go through this list. This is very important in practice point of view and also exam point of view. Okay, again, neurocutaneous syndrome, we'll not discuss them in detail, just go through the important one. Okay, just see the FACE syndrome. The full form of this is very much important, has been asked multiple times. Posterior fossa malformation, hemangioma, arterial lesions, like dysplasia of cerebral arteries, cardiac defects, coaction of aorta, ocular defect, ventral defect, and sternal clefting, very much important. Again, next, incontinentia pigmenti has been asked multiple times in this. This is IKBKG inhibition, and this disease is X-linked dominant. Linear nevus sebaceous is HRAS, KRAS, and NRAS, asked multiple times. Von Hippel-Lindau disease VHL autosomal dominant. NF1, NF2, and tuberous sclerosis complex you have to study in detail. We will not discuss them here. So just see highlighted portion of this slide. Okay, this is Crowe sign. Repeat exam question. What is Crowe sign? This is axillary Franklin, and this is a pathognomic sign of neurofibromatosis. What is pathognomic sign of neurofibromatosis? Is axillary Franklin, also called Crowe sign. This you are able to see pigmented hamartoma on iris leash nodule. So this leash nodules has been asked multiple times. They are pigmented hamartoma of iris. These are very important. Optic glioma you are able to see in this NF1 patient, and these are UFO, unidentified bright object, not UFO, sorry, unidentified bright object, UBO. Okay, so these are findings in MRI. In case of tuberous sclerosis, just go through these images. These are very important and favorite for examiners. So in first image, you are able to see hypomelanotic macules. Okay. Second image showing facial angiofibroma. Third image is showing shagreen patch. Next image showing hyperechoic rhabdomyoma in echocardiography. Retinal hamartoma you are able to see, and lymphangiomyomatosis. So these are classical things seen in tuberous sclerosis. Other thing, are you able to see subependymal calcification? Are you able to see calcification? Yes, these are subependymal calcification and multiple subependymal nodules. Are you able to see in this MRI? So this is very much important tuberous sclerosis findings. Okay, major there are major features of tuberous sclerosis complex and minor features. They are very lengthy to remember, but unfortunately they are favorite for examiners. So how you will remember? So we will remember only minor features. If anything apart from minor will land up into major features. Okay, so dental enamel pit, intraoral fibroma, retinal achromatic patch, confetti skin lesions, non-renal hamartoma, and multiple renal cyst. These are actually minor features of tuberous sclerosis complex. Just pause this video and somehow remember this. Okay, I'll tell just see, I'll tell difference between them. Okay, renal angiomyolipoma is major, but multiple renal cyst and non-renal hamartoma are major. Okay, other thing you found facial angiofibroma is major, but confetti skin lesions is minor. Okay, so just remember these are very important. Just remember minor features. Okay, port wine stains, in which conditions they are associated? Again, important question. Sturge-Weber, macrocephaly capillary malformation, MCM syndrome, Cobb syndrome, Bunyan-Ridley syndrome, VHL, and Robinson-Tybee syndrome. So just remember only highlighted portion of this. So this is showing port wine stain, and MRI showing Sturge-Weber syndrome, leptomeningeal enhancement in left hemisphere. Are you able to see leptomeningeal enhancement? Okay, type of cerebral palsy, all we know, this is very simple. Most common is spastic dysplasia due to periventricular leukomalacia. Spastic quadriplegia is also associated with multicystic encephalomalacia and cortical malformation. Hemiplegia is 25%. Extrapyramidal CP is asphyxia, kernicterus, and mitochondrial. So this is for CP, cerebral palsy. Okay, so the clinical feature should prompt for evaluation on genetic or metabolic of causes of CP. So absence, any history of perinatal risk factor, developmental regression, progressive neurological symptom because this is non-progressive disease, clinical exacerbation, prominent ataxia means any signs and symptoms which are not classical to CP go for genetic testing. You found a MRI and a case of CP was evaluated, but anything other than CP findings were found. If hypomyelination was found in MRI, think of PLP related demyelinating disorder. Very important. This table is CP mimics. Uh, any actually a favorite for INICT, not this NEET SS, but INICT favorite. Demyelination, Krabbe's disease and metachromic leukodystrophy, thin corpus callosum, HSP, globus pallidus lesions like NBAI, hyperintense, focal atrophy or hypoplasia seen in glutaric aciduria, HABC, and Joubert syndrome. Okay. Uh, okay, we have come like half of this discussion. So be with me and trust me, this is bare minimum you have to remember in this CNS, which is very vast topic as such. Autoimmune encephalitis we'll see opsoclonus myoclonus, okay, which is associated with neuroblastoma. Just remember this. Bickerstaff encephalitis associated with GQ1 antibody, very important, associated with ophthalmoplegia, ataxia, and decreased level of consciousness. Rasmussen's encephalitis is due to progressive refractory partial seizures and cognitive decline. and MRI suggestive progressive unilateral hemispheric atrophy. Clipper syndrome, previously as syndrome, it is no specific antibody association, possibly represent different diseases, important differential diagnosis of lymphoma. So it was actually lymphoma DD. Rohard syndrome, I don't know why it is favorite, it was repeatedly, I think, thrice in exam. So the syndrome full form is rapid onset obesity, hyperphagia, abnormal behavior, autonomic dysfunction, and central hypoventilation. Sometimes autoimmune genetic associations are associated with the neural crest tumors, and some antibody association against J, ZSCAN1. Just remember this. Symptomatic treatment is required. Okay, this is again PYQ. This is extreme delta brush pattern of gene NMDA encephalitis. Just remember this image. Okay, this is very important. The acute demyelinating disorders of CNS. Adam multi this is actually Adam, multiphagic Adam, multiple sclerosis, Moog associated demyelination, and neuromyelitis optica spectrum disorders. Adam actually, just remember, Adam is first event and no new symptoms, sign or MRI finding after initially 3 months, and actually they are bilateral, diffuse, poorly demarcated lesions. So this Adam is first episode. Moog positivity is seen in 50% cases of Adam, previously asked question. Multiphagic Adam, new onset of Adam 3 months or more after initial event. So this will be caused as multiphagic Adam, and Moog antibodies associated 100% cases. So Moog association 100% multiphagic Adam and Adam per se 50%. Very important. Multiple sclerosis, again very important. MS, there is no better explanation, both dissemination space and dissemination time. So in this condition, dissemination space is demonstrated by at least two of the following CNS sites like periventricular, juxtacortical, infratentorial, spinal cord, or dissemination of time. One of the following is simultaneously present of MRI of one or more enhancing or non-enhancing lesions, CSF oligoclonal bands, follow-up MRI more than 30 days showing one or more lesion, and two or more acute episode. Typical MS is lasting more than 24 hours. So just remember, these are very specific criteria. Just go through these ones. Just pause this video and just go through these. Moog associated and demyelination, AMDAM, ADAM-ON, optic neuritis, NMSOD. We'll discuss this. NMSOD, neuromyelitis optica spectrum disorders, can be classified if aquaporin 4 positive. One of the following one core criteria is required: optic neuritis, acute myelitis, area post-nervous syndrome, acute brainstem syndrome, narcolepsy. If aquaporin 4 negative, two core criteria. At least one criteria must be of optic neuritis, longitudinal extensive TM. If Moog antibody positive with both ON and TM, then Moog plus NMSOD may be diagnosed. So this is exhaustive table. What you have to do, just pause this video, rewind this table once again, and try to remember. Very important in your clinical practice as well as exam point of view. Okay, so these are actually differential diagnosis of multiple sclerosis. Just remember, see the highlighted portions. Okay, so MS differential diagnosis, neurosarcoidosis. So in this condition, uh, serum AC is increased. Susac syndrome. This is actually visual loss, sensory hearing loss, focal and small lesions. CADASIL, very important. Migraine or stroke-like event, temporal pore lesion, external capsule and U fiber lesions, very important. Just go through highlighted one. Neurobachet syndrome, brainstem syndrome, HLA-B5 association, and Clipper syndrome. So this is exhaustive looking. Sorry for bombarding you with this exhaustive looking table in CNS discussion, but for exam point of view we have to remember these all. So just bear with me. Acute flaccid myelitis, that clinical mimics. Okay, we have to differentiate basically acute flaccid myelitis, GBS, transverse myelitis, and spontaneous cord infarction. Just be with me. Okay, if in acute flaccid paralysis, asymmetric weakness is there, but in GBS, symmetric ascending paralysis is a hallmark of GBS. In spontaneous spinal cord infarction, also symmetrical involvement is there. And you know, uh, ours today is acute flaccid paralysis, but GBS and transverse myelitis, it may take days to week. Okay, sensory level is present in transverse myelitis and spinal cord infarction. Just remember, no sensory level seen in acute flaccid myelitis and GBS. Very important. Encephalopathy is not seen in any of those except ADAM. Bladder bowel dysfunction are not prominent feature of GBS and acute flaccid myelitis. If they are present, you have to think of another syndrome or disease. So just remember highlighted portion. Again, I'm recording this video in a flow, but you can pause this video and remember or try to analyze the things and go forward then. Okay. So again, we are into neuromuscular disorders. So specific congenital myopathies are asked. So what are the myopathies? Just remember central core disease, Nemelan myopathy, myotubular myopathy, congenital fiber type disproportion. So what you have to remember, just remember all congenital myopathy will have neonatal hypotonia and weakness. Neonatal death is not there in central core disease, except all diseases will be present. Facial weakness will be present. What is the differentiating feature is ptosis. Okay, myotubular myopathy has ptosis, no other congenital myopathy. So T4 ptosis and T4 myotubular myopathy. You can remember this. Extraocular muscle weakness is seen in obviously myotubular myopathy along with congenital fiber disproportion type myopathy. So just remember these two, ptosis and extraocular muscular weakness. Two things you have to remember from this table. You'll be good to go. Okay, SMA, very hot topic nowadays. Examiner ask very much. So what are the variants? Homogeneous deletion of exon 7 is this molecular genetic testing is done, which is actually detection rate is 95 to 98%. If one test you will be asking, you are asking. So homozygous deletion of exon 7 is the very important or important test. Other compound heterogeneity deletion of SMN1, SMN2 copy number you can see. Okay, next very important. What are the drug therapy for SMA? The first drug, the star drug is Nuziserine. What is the brand name? Spinraza. Okay, it is approved for all ages. These are all PYQs. Just trust me. Okay, what is the mechanism? Action is antisense oligonucleotide promoting inclusion of exon 7. Very important. Next drug is Zolgensma. The full name is very long. Just see onasemogene and all that. What is this? That is important. It can be given less than 2-year old also. This is IV one-time dose. This is gene replacement therapy, my friends. AAV9 vector. Okay, next drug is risdiplam. This is more than 2 months. This is oral drug. Which drug can be given orally? This drug can be given orally. And what mechanism of action is? Small molecule spice modifier promoting inclusion of exon 7. Just go through this slide. This is very high, trust me. Okay, so diagnostic criteria of GBS. Nowadays, GBS cases are increasing in our country. So, the features needed for GBS is progressive weakness in leg and arm. This is ascending symmetrical paralysis as we discussed. Areflexia in weak limbs. So weakness, which is ascending and symmetrical with areflexia. This is essential. Additional symptoms, it may last for 2 weeks. Symmetrical, mild sensory symptom, or no severe sensory symptoms should not be there. Cranial nerve involvement may be there. Autonomic dysfunction, pain is common. Other factors should raise doubt. You read by yourself. Any factor apart from this can raise doubt of, like any strong sensory level can cause doubt. Any bladder bowel dysfunction, fever at onset, sharp spinal levels can actually indicate other than GBS. Okay, very important. Etiology of acute peripheral facial palsy. So the point of this table is Lyme disease was asked. So Lyme disease is a cause of acute facial palsy, but the Bell's palsy, which is idiopathic, is the most common cause of peripheral facial palsy. Herpes and varicella zoster is also important. Other disease, you can list of diseases including infectious and common association are given, but Lyme disease is important. This previously asked question. Okay, now we'll try to cover other topics or important points as a one-liner. So be with me. You can get 3 or 4 questions from these one-liners, which will be very important. So just go through fast. Neural tube closure occur by 28 week of gestation. Anterior neuropore failure leads to encephaly. Posterior neuropore failure leads to spinal bifida. Cortical migration defects. What are the cortical migration defects? Are legencephaly, sygenocephaly, polymicrogyria. Okay, hydrancephaly. The cause is bilateral ICA occlusion in utero. Previously asked question. Dandy-Walker malformation. Again, previously asked question. Is cerebral vermis hypoplasia plus cystic fourth ventricle dilatation. What is Chiari? Second malformation is a hindbrain herniation plus myelomengocele. When corpus callosum develops between 8 to 20 weeks of gestation, previously asked question. Okay, germinal matrix hemorrhage is most common in preterm. All we know, PVL is a leading cause of cerebral palsy in preterm. The jitteriness is differentiated by seizures with autonomic changes. Neonatal seizures are most due to hypoxic ischemic encephalopathy, and pyridoxine-dependent epilepsy is treatable cause of neonatal seizures, often intractable. Benign neonatal seizures, fifth day fits, are due to transient immaturity of KC and Q, KC and 3 channels. This is a favorite question of examiner. Benign neonatal seizures, fifth day fits. Glucose less than 45 is considered as hypoglycemia. Connectors is damage of globus pallidus, subthalamic nucleus and cranial nuclei. Okay, I'll go important one. HIE is diagnosed with AEG, and GABAergic system is immature at birth. Okay. So, infantile spasms are associated with hips arrhythmia on EEG. ACTH and vigabatrin is first line of choice of drug in West syndrome. Dravet syndrome is due to SCN1A mutation. Important one. Panettiopoulos syndrome presents with autonomic seizures plus eye deviation. Lennox-Gastaut syndrome, as we discussed earlier also, shows slow spike wave and 1.5 to 2 Hz on ECG, absence seizures 3 Hz, we all know. Landau-Kleffner syndrome, acquired aphasia with electrical status epilepticus in sleep. Acquired aphasia term is important. Status epilepticus, all we know, seizures lasting more than 5 minutes. Metachromic leukodystrophy due to URSA mutation, Krabbe's disease due to galactocerebroside deficiency, adrenoleukodystrophy is very long chain fatty acid. So again, I'm repeating, I'm going very fast. Just pause this video and revise these important points. You will be get benefited from this. Okay. So mitochondrial disorders are diagnosed by muscle biopsy showing red fiber. Gaucher disease, the crumbled paper macrophages in bone marrow, again PYQ. Pompe disease, hypertrophic cardiomyopathy with hypotonia, again PYQ. Glutaric acid urea type 1, subdural hematoma and frontotemporal atrophy. Rett syndrome MECP2 mutation, hand-wringing movements are seen, PYQ. Wilson disease, all we know. DMD, the gene in XP21. Okay, myotonic dystrophy type 1 is due to DMPK gene CTG repeat mutation. SMA and Pompe, we all know. Lambert-Eaton syndrome is caused by autoantibody against presynaptic calcium channels. GBS, all we know, Campylobacter jejuni infection. Botulism presents in floppy baby, constipation, descending paralysis. Okay, so Neurocutaneous syndrome we have discussed in detail, so we do not go with them. Okay, Moyamoya disease, progressive stenosis of ICA with collateral vessel formation. Stroke in children is most commonly due to sickle cell disease. Arterial ischemic syndrome in neonate involve left middle cerebral artery most commonly. Okay, so hydrocephalus, basically non-communicating hydrocephalus is due to aqueductal stenosis, and communicating is due to impaired CSF absorption at arachnoid granulation. So Brown-Sequard syndrome, all we know, it's ipsilateral motor loss with contralateral pain and temperature loss. Okay, just be with me and just revise them again. No point seeing a video and leaving it behind. Just pause this video, revise again and again, and you will get neck of it. Okay, so spinal cord trauma at C3-C5 cause diaphragmatic paralysis. Neuroblastoma is most common extracranial solid cranial tumors. CSF pleocytosis GBS called albuminocytological dissociation. We discussed opsoclonus myclonus syndrome is associated with neuroblastoma. Wilson disease in MRI showing panda sign in MRI. Locked in syndrome, the PYQ question, results from ventral pontine infarction. Adam is monophagic, we discussed. MS, we discussed also. We discussed this in detail. Okay, Miller-Fisher variant of GBS question presents with ophthalmoplegia, ataxia, and areflexia. Chronic inflammatory demyelinating polyneuropathy (CIDP) is GBS lasting more than 8 weeks. Very important. Rasmussen's encephalitis is progressive unilateral inflammatory epilepsy syndrome. Autoimmune encephalitis includes NMDA receptor encephalitis and paraneoplastic cerebral degeneration (PYQ) in INICT associated with anti-FU, anti-U, and anti-TR antibodies. Okay, Kenwan disease is due to ASP gene mutation. Alexander disease is characterized by Rosenthal fibers in astrocyte. Biotinidase deficiency is presents with alopecia, seizures, hypotonia, and metabolic acidosis. Zellweger syndrome is a paroxysmal disorder with craniofacial dysmorphism and hypotonia. And maple syrup urine disease due to branch chain ketoacid dehydrogenase deficiency. Homocystinuria mimics Marfan syndrome but intellectual disability and thromboembolism. Okay, Menkes disease, all we know, copper transport deficiency. Okay, cerebral palsy is most common spastic diplegia subtype. Syndrome Core's post-streptococcal basal ganglia disorder. What is Segawa disease PYQ? This is DOPA responsive dystonia. Okay, Friedreich's ataxia Wilson disease, all we know. Essential tremors improve with alcohol and treated with propranolol and primidone. Question PYQ. Tourette syndrome again. Childhood tic disorder associated with OCD and ADHD. Okay, so congenital myopathies, all we know. This gene is XP21 and CK levels are markedly elevated. X-linked recessive and steroids are used. Okay, so yeah, SMA gene is 5q, again multiple time asked. Type 1 is Werding-Hoffmann disease, death by 2 years. Type 2, children sit but cannot stand. Type 3 is Werding disease, late onset, and all we know, Nusicerin and gene therapy Jolenskisma are approved. Okay. Polymyoclonus is characteristic to SMA type 2. Again, INICT-PYQ. SMA spares extraocular muscles, differentiating it from myasthenia gravis, very much important. Okay, so Pompe disease, cardiomyopathy, acid maltase deficiency is seen in Pompe disease, all we know, and carnitine palmitoyltransferase (CPT) second deficiency causes exercise-induced myoglobinuria. Again, repeat question. McArdle disease type 5 GST, exercise intolerance and second wind phenomena. Which disease cause second wind phenomena? It is McArdle GST type 5. Mitochondrial myopathy shows red rag fiber muscle biopsy, and uh, glycogen storage disease affecting skeletal muscles causing weakness after exercise. Raynaudin receptor mutation causes malignant hyperthermia. Okay. Nemaline myopathy presents with hypotony and facial weakness. Okay. So, endothelium test is positive in MG. Pyridostigmine is the first line treatment for MG. Lamberton-Eaton myasthenic syndrome (LEMS) is caused by anti-presynaptic calcium channel antibodies. Okay, next, peripheral GBS, all we know. Campylobacter jejuni infection more than 70%. Miller-Fisher variant we discussed. Ophthalmoplegia, ataxia, areflexia, and CIDP we discussed. GBS lasting more than 8 weeks. Okay, Charcot-Marie Tooth disease, again PYQ twice. Most common inherited neuropathy. CMT type 1A caused by PMP22 gene duplication, and Rosby-Levy syndrome is CMT with tremors. So this was it for pediatric neurology for NEET SS. It was very actually fast revision. So I tried to cover as many things as possible in a short span of time in 1 hour approximately duration. So as we all know, neurology can't be completed in 1 hour. So these are bare essential for I have compiled all important or previously asked topics from neurology. So what you have to do now, your work is remaining. You have to revise and repeat this video again and again, and try to consolidate the things which I have discussed. So hope your CNS, your score from neurology will increase in upcoming exam. I will be continuing this amazing series with next system. So stay tuned and updated, and do share, like and subscribe. We'll meet in another interesting video from this part. Okay, till then, stay happy, keep studying.